patient was 76, and my patient's diagnosis was a small bowel obstruction. A small bowel obstruction is when it's just what it sounds like, it's when there is an obstruction of the small intestine. My patient had the obstruction of the small intestine because of a hernia. And the clinical manifestations that the patient was experiencing included constipation and severe abdominal pain. And then her past medical history included a right hip arthroplasty 3 years ago, in 2015. With her physical assessment, she had a right angiocath 20 gauge saline lock, and then she also had a left brachial saline lock. This patient was on room air and had a surgical wound on her right lower abdomen. Her right upper abdomen. So the surgeons could fix her small bowel obstruction. This patient had support from her daughter. However, she didn't have other family members to lean on, and her psychosocial needs included needed to be comforted, as she was unsure if she was an adequate person in her daughter's life, as she was concerned that she was too big of a burden on her daughter. And then her physical needs included her care in the hospital. Other than that, she didn't have any other comorbidities except for hypertension. Besides this hospitalization, she was a pretty healthy individual. Her medications that she was on at the time included amlodipine for hypertension. She took 5 milligrams orally daily, and side effects for this medication are anaphylaxis, hypotension, and heart palpitations. Precautions and contraindications include hypersensitivity, heart failure, severe hypotension, chest pain, and that's actually it. And then nursing implications for this medication include monitor for a decrease in hypertension, as that's what the medication is for, assess for all the side effects and anaphylaxis, evaluate blood pressure, heart rate, and assess for chest pain. Another medication that the patient was on was calcium. She was just taking a calcium supplement to increase her calcium levels as a dietary supplement. Some side effects of this can include muscle cramps, heart arrhythmias, an increase in thirst and urination, and contraindications and precautions include hypercalcemia, hypersensitivity to the medication, and a myocardial infarction, as well as hepatitis. For this, you want to monitor for an increase in calcium level, so you will assess blood work, and then you will also assess for muscle cramps, heart rate, intake and output, and any chest pain. This patient was ordered heparin. However, this patient refused taking heparin as she didn't like the side effects, as it was an injection and she had localized skin reactions to it. Heparin is, of course, an anticoagulant, and she took it for anticoagulation and perfusion. She took 5,000. She would have taken it subcutaneously every 12 hours. However, while I was there on the day of care, she refused. Side effects of this medication include an increase in bleeding, a hemorrhage, hyperkalemia, and GI bleeding. Precautions and contraindications of this medication are hypersensitivity, thrombosis, myocardial infarction, gasping syndrome, and elderly patients, which she was considered an elderly patient, so we wanted to be cautious with that medication if she were to take it. With this, you would want to monitor for an increase of perfusion, and you would want to assess for tarry stools, hemorrhaging, potassium levels, respiratory rate, heart rate, and a hypersensitivity reaction. And then she was also ordered acetaminophen for pain. With this, you would want to inform the patient not to exceed 4 milligrams over the course of 24 hours. Precautions and contraindications of this medication are a known hypersensitivity, hepatic impairment, acute liver failure, and the use of alcohol, and Stevens-Johnson syndrome. Side effects of this medication include hepatitis, abdominal pain, and hypersensitivity. Alright. Some diagnostic testing that she had done were a BUN to check for her kidney function, and that came out a little high, and so this means that her kidney function was not as adequate as it should have been. And then she also had a low total protein, which could be due to her not wanting to eat as she was in pain, so she was not getting an adequate intake of protein. She also had an abdominal x-ray for her pain originally, and that's how they found the small bowel obstruction. And then she also had an abdominal CT scan, and this means that, or this was to see a total 360 view of her abdominal organs, or abdominal organs. And they found the small bowel obstruction on the x-ray. And so with the CT scan, they found multiple small fluid-filled bowel loops, a hiatal hernia, and an intrathoracic stomach, which was distended and had fluid in it. Other disciplines involved in her case include physical therapy and case management. She was talking to me about getting a swing bed for when she went back to the nursing home, the long-term care facility that she was at, and case management came and talked to her about when she would be able to get that swing bed and how they would be able to pay for it. This patient's mobility was at an 18 for the fall risk assessment, and then for skin breakdown, this patient was at a 16 on the Braden scale. This patient is definitely a fall risk, and we made sure throughout the day that she was always an assist of 2. Man, it's getting kind of hot in here. I just gotta take this off. Some good air. The patient, while I was there on the day of care, was experiencing diarrhea, and this was expected post-op with her complication, and the diarrhea wasn't too severe, and this patient didn't want to take any medications to harden her stool. Her past medical history didn't impact her care today that much. She actually used to be a nurse until she was 55, and as I was talking to her, she was talking about how she knew how she should be treated, and if she wasn't being cared for properly, she was very much okay stating that, and she said that it made her more comfortable as a patient because she was comfortable in the hospital setting. And then she said that she was also used to being in the hospital as she had her right hip arthroplasty 3 years ago. Complications that I was assessing for included abdominal distension, guarding, skin breakdown because of by her surgical incision, fluid and electrolyte imbalance, post-operative signs of infection, and inadequate airway maintenance, and inadequate breathing. The diagnostics that were ordered to ensure that they had the proper diagnosis, and they wanted to ensure that her electrolyte levels and blood serum levels were normal to see if we needed to do anything about that or give her any medications or other supplements to ensure her good health. The patient had 2 IV lines placed during surgery, and then the surgeon decided to leave them in case the patient needed to have future running fluids, in case any labs did come back abnormal. They didn't want to have to restick the patient. As discussed, we already talked about why the patient was on the medications that she is on. It does make sense for this patient, and she said that she's not experiencing any side effects except for when she takes heparin, hence why she refused to take heparin. The patient stated that she felt as though she had a ton of support from the hospital staff and other disciplines. She said that she had nothing but good experiences in the hospital that we were at. Other support included the case management, the surgeon, dietetics. And then the safety precautions that need to be considered are fall risk for infection because she was a post-operative patient, risk for aspiration, risk for developing lung infections as, again, she is a post-operative patient, risk for pneumonia as she was in bed most of the day, and then risk for bed sores as she has frail skin just due to old age and a decreased elasticity. For prioritizing care for this patient, I had as a number 1 priority, I had a risk for aspiration related to lack of knowledge as evidenced by a patient was drinking water while laying down in bed. For this, nursing interventions I completed included teaching the patient about aspiration. As I taught the patient about aspiration, she reminded me that she was a nurse for a long period of her life. She was like, I know, but I'm doing it anyway. So I wasn't entirely sure what to do about that, but we had a good conversation about it. And I also raised the head of her bed to 30 degrees, and then I assessed her respirations. The second one was impaired circulation related to lack of movement, as evidenced by patient laying in bed for multiple hours on end during the day of care. With this, I encouraged the use of the patient's ordered heparin to promote adequate blood flow and perfusion. I ambulated with another assist with the patient, and I educated the patient about the importance of movement for circulation, in which case she thanked me and was grateful that I did remind her about the importance of movement for circulation. The third patient problem that I talked about with the patient was impaired mobility related to pain, as evidenced by the patient stating, it hurts to walk because of my arthritis and I'm stiff. With this, nursing interventions that I had were assess pain in more detail with the patient, administer pain medications per physician order, and which was the acetaminophen, and teach distraction techniques for the patient's pain. Other interventions include respiratory care, like using her incentive spirometer to decrease that risk for pneumonia and increase perfusion. And refer the patient to an occupational therapist for help with this patient's arthritis and her activities of daily living, as she was concerned that she was being a burden on her daughter. And then other therapies, again, just talking about using the incentive spirometer and also taking her heparin, so medication therapy. With the referrals that may be necessary, as I already talked about, I would refer the patient to an occupational therapist, and I would also refer the patient to a counselor, as she was very stressed about being a burden on her daughter, as she mentioned it to me multiple times throughout the day. Evaluating all of my interventions. The patient teaching about aspiration, she responded with telling me that she already knew about it. However, she continued to, she laughed at me teaching her about it and didn't want to change her habits of drinking while laying down. Raising the bed of 30 degrees to decrease her risk of aspiration. The response to that was she did not aspirate, thank the Lord. And I assessed her respirations, and her respirations were within normal limits. For impaired circulation, the outcome of encouraging the use of heparin was we had a good conversation about the side effects of heparin and the benefits, and hopefully that allowed the patient to think about actually starting her heparin again. I ambulated with an assist with the patient in that increased her circulation, as evidenced by her capillary refill was less than 3 seconds, and before ambulation, her cap refill was 2 seconds. Her capillary refill was 4 seconds. Before ambulation, and then post-ambulation it was 3. And then after educating about the importance of movement for circulation, this encouraged the patient to talk to me about moving and how she felt about it. And then the outcomes for impaired mobility that we talked about, when I assessed pain in more detail with the patient, she was able to tell me further about her pain, and I was able to chart that. Administering pain medications per physician order, she went from a pain of a 3 to a pain of 1 an hour later, so that was a good thing. And then teaching distraction techniques for pain, she started deep breathing techniques after I taught them to her. Total care of this patient went really well. She was incredibly nice, and I believe that our conversations were really great and really beneficial. And something that didn't go well, though, and didn't go as planned, her IV ports were not patent, and when we tried flushing her IV ports, they had phlebitis, as the ports were old and hadn't been used since surgery, and they had not been flushed previously, post-op. So that was interesting, and we took out her IV ports and de-seeded them. And then she didn't have to have any re-put in because she was being discharged soon. I felt really confident about teaching the patient about her care because she was very engaging, and she acted like she wanted to learn about her condition and how she could improve her overall outcome faster. Learning as a nurse, I learned that even when I am nervous in front of a patient, I learned that confidence is key, especially when talking about a patient's healthcare. Confidence is key as long as you are sure with what you're saying. It was just interesting to have a conversation with a patient who was previously a nurse. So I gained a lot of confidence as I learned a lot today. And I do believe that the patient is receiving adequate and appropriate care, except for the fact that her ports had not been flushed before I, as a student nurse, flushed them. So that was interesting. It was an interesting finding, and I was grateful that I was able to actually help the patient out in a decently significant way. And that's it for today. That is all about my patient, and I hope you have a great rest of your day. Thank you.